Hello, I'm Janice Karin, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I'm on our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activities. Join us for this week's updates. And if you'll go ahead and move to the first update. HHS has put out some documents talking about their new health IT alignment policy. The new ASTP ONC was tasked with promoting greater alignment on July 28th. They were given 4 goals for this. As you can see, I'm not going to read them word for word, but basically to promote consistent agency-wide approaches to health IT requirements, including limiting and hopefully getting rid of things like data silos and program silos so that things are more consistent across the whole agency. Also, on that note, to promote cross-agency collaboration and better support each of the agency's missions cohesively. Support goals for nationwide interoperability, and then also promote awareness of significant health IT activities. Any questions about what they're trying to accomplish? All right, let's keep going on the next slide. This is actually a 3-slide update. So there are 2 major areas that they've called level 1 and level 2. Level 1 is the inclusion of standard health IT language in various agreements to the extent that it's legally possible. They're going to use standard language in any agreements, particularly HHS contracts, that require the full use of certified health IT wherever applicable or available, supporting the HHS approved standards when applicable and available. And if there are no HHS approved standards for something, then the use of other HHS identified, or if there aren't other identified, then not other non-proprietary open industry standards for those things. So all of the contracts moving forward from HHS will include those types of requirements. And we'll come back to that because there's actually there's a little bit more on the next page, but also an update entirely. They've already started moving forward on that front. So level 2 is that there's going to be ASTP review of activities across all of the sub-agencies within HHS, and also more technical assistance provided. So each of the agencies, sub-agency groups are going to have liaisons that ASTP will work with to develop and maintain HHS-wide inventory of different health IT activities. And the activities that must be part of this list are activities that involve more than $20 million in funding annually. I don't know why they put both of these statements in. To me, it seems like they're this identical, but I'm not sure why. There might be something magical about the way that contracts or funding gets done that require specifying both of these items. But basically, from a practical standpoint, any program that has more than $20 million of funding on an annual basis will be part of this program. And it also have economically significant rulemaking or guidance. It is not clear if something has to meet only one of these criteria or both of them. So I suspect it's one of them, but that was left up to the reader without any clarification. So any questions, thoughts, or comments here? All right, well, let's go on to the last page of this then. So they talk a little bit, there's actually a blog post that accompanies the policy information, and that focuses a bit on the activities that are already underway. So one of the things I mentioned we'd be coming back, there's actually already a proposed rule around the procurement activities and the contract requirements, and we'll get into that. That's the next update. We won't really go into much more detail than what we already talked about, though, because that's really the high level takeaway. But they've also identified, done like an initial sweep and identified billions, in their words, billions of dollars worth of projects that qualify for the technical assistance and coordination. And then they mentioned two areas where they're already providing technical assistance and subject matter expertise. One of them around public health guidance for grants and cooperative agreements with the CDC, and then also with CMS working on new initiatives. The one they called out specifically was a new CMMI maternal health alternate payment model. But they made it clear there are other things as well. This is the only one they called out. So you can, the first link there goes to the new webpage on the health IT alignment policy. That actually is a little bit of a bare bones overview, and then it links to the actual policy document and a few other things. And then the second link is that blog post I mentioned that talks a little bit about the program and then the current activities that are already underway. So any questions or comments about anything with the health IT alignment policy? All right, then let's go on to the next slide and talk about that proposed rule. So this basically is the first step in implementing the procurement portion of the policy. This was published last Friday, August 9th. Comments are due on October 8th. That's basically 2 business days after the HTI 2 comments are due. So that's going to be a little bit interesting. So what it covers all health IT that is procured by or on behalf of HHS entities, as well as health IT that is procured using HHS contracts with payers and providers that involve implementing, acquiring, or upgrading health IT. So if anyone here has some type of grant program or is part of some type of program that any HHS agency has provided to help fund specific pieces of health IT or to help expand or use certain parts of health IT, I believe those would now be covered under this agreement moving forward. It require, and again, this sort of is similar to, this is where there's some overlap from the previous slide where we talked about the policy generally, but basically the terminology that it uses is for health IT that is meant to exchange any individually identifiable health information. So basically any PHI. So if there's health IT that involves any type of data exchange of PHI, you must, again, meet the standards and implementation specifications that are adopted by ASTP. Now, the implementation specifications means that, so that implies specifically some of the new implementation guides that are being adopted as standards. So for instance, the CRD, DTR, and PAS guides for prior auth are implementation specifications that are adopted by ASTP. To give an example, once assuming that the HTI2 rule gets finalized the way that it's currently written from that perspective. So you must meet non-proprietary industry standards developed by consensus-based standards development organizations if there isn't an adopted standard above that applies. So this is sort of a slightly further enlargement of what qualifies as the open standards if you can't use a ASTP standard. So So they are actually specifying in the rule that it must come from a consensus-based standards development organization, and not just the policy document had just sort of said open standards. So it wasn't at the specific about what that meant. So this is actually a higher standard of requirement. And then if an ASTP certification exists, then the health IT must be certified under it. So you can find the full proposed rule at the link. I have not read the entire rule, so it's possible there are some other little pieces that will float up that wind up being important. But for the most part, it is the implementation piece of the procurement part of the plan that we just looked at. So any questions or comments or thoughts here? All right, let's keep going. So last week we looked at some new quality measures that would be required for Medicare promoting interoperability. And CMS has scheduled some office hours if folks have any questions about them. The one that's specifically scheduled September 6th at 2 p.m. is for electronic case reporting. And then sometime in October, they're going to have a similar hour for the antimicrobial use and resistance measures. There's no like open registration. If you want to attend these, if you have a question and you want to attend, you actually have to email a particular person at CMS, and I will happily give that email address to anyone who wants it. The sessions, the open office hour sessions will be recorded. The recordings will not be made publicly available, at least not, they won't be posted for anyone to see, but they will be made available to anyone who requests a copy. So they will be shared, they're just not going to be publicly posted. So they're holding these a little bit tighter than they normally would do for any type of public interaction, which is kind of interesting. But I thought I would mention it. It came via email, so I don't have a link about it. And if you are interested in attending, let me know and I will send you the email address that you need to use to request attendance. Any questions? All right, let's keep going then. So this update, this survey was kind of interesting. So Health IT Answers published some of the top level takeaways from a recent survey from 2024, which is part of why it's notable because we rarely get data that quickly. Of more than 1,500 patients, and some of the takeaways, they basically talked about 3 different areas in the high level takeaways. The first one was about patients indicating that they have difficulty with appointment scheduling, particularly when they're trying to cancel or reschedule existing appointments. And the data showed that more than 50%, I think it was actually slightly under 50%, but right about 50% of the folks in the survey would avoid calling to cancel or reschedule because of long wait times and just end up being no-shows. Of the people who responded, 23% cite lack of online options as a barrier to this task. There was a discussion, though, there was a big generational divide around wanting online options versus phone. And they make a big point of saying you really do need both at this point. So none of that, that last bit isn't particularly surprising. The fact that 50% of people nope out is interesting. And I wonder if it's that they avoid calling or they just can't get through. I know personally, I have a horrible time getting through at this point. The staffing levels for all of the phone lines have gone way down since the beginning of COVID, and they haven't ramped back up. And so it is incredibly difficult to get through by phone to providers, pharmacies, almost any clinical or care situation. So that was my one thought here. Anyone else want to comment on that before we move on to the next topic? All right, then let's talk about getting prescription refills. Can you go back up, Denny? Um, so some patients had reported having difficulty getting their prescriptions refilled and sometimes forgoing them. And here you can see that 20 to 30% of folks cited a couple of different reasons: lengthy hold times, cumbersome processes, limited provider hours, etc. And that about a third of the people said they've had some type of setback or complications from delaying their refills. What I found interesting here is that no one mentioned supply chain issues, and no one mentioned issues with changes to their coverage or prior auth requirements or things like that. And I'm wondering if those were options in the survey. I know, again, not to make this all about me, but I've had supply chain issues each of the last 3 or 4 summers on stuff. And that's probably been the biggest problem. But there's also been a lot of changes to what does and doesn't require a prior auth. And so that has also caused some delays. And again, that's just my personal one person's data. But certainly I don't think I'm alone in that. So I thought it was interesting that those were not surfaced, and I'm wondering if they were offered as options. So anyone have any thoughts or comments on prescription refills before we move on to AI? All right, let's keep going then to the next slide. So about 30 to 40% of patients indicated that they were open to using AI for administrative type tasks, things like inquiries about hours and locations, appointment management, finding providers, stuff like that. Of the people who've already had experience with AI or have thought about it extensively, so about 81% of folks have used some type of chatbot or AI voice assistant for healthcare use in the past year. So that's actually pretty high. That's higher than I would have expected. However, only 41% report having a positive experience. Actually, that's still probably higher than I would have expected, but it's still pretty low. If you had a 41% satisfaction rating for something that you're doing, that probably means you need to rethink how you're doing it. However, sort of tying into the other thing, the other data about hold times that came up with the rescheduling, 84% of folks said they would prefer to speak to an AI if the hold times are too long to get to a real human. And about 2/3 of folks said that they expected that this was the year when generative AI would start being a real thing at their providers for online and phone support. So I thought that was interesting because that's a bit of a mixed bag. However, they then asked, they kind of followed up with, what are your biggest concerns about AI? And it appears this is the top concern. So you can only pick one of them, which is why you'll see it's about 1/3, and a quarter, with that last little slice probably going to other options. So about a third of people said that privacy and security was their top concern, but about a third also said accuracy and reliability of the AI responses. And honestly, that's probably where I would fall given my previous experiences. And then about a quarter, lack of human interaction and personalized care. So you can find more information, including a link to the full survey at that Health IT Answers article. But does anyone want to comment or have any thoughts on these results, or want to share any additional things that they think should have been on the survey and aren't, or things like that. All right, then let's go ahead. If you go to the next page and pause, I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@mahealthdata.org. That email address is also on your screen.